students, welcome. Myself Dr. Roshini, your OBGYN faculty. So today we are going to discuss another question paper. Yes, today we are going to talk about the NEET 2021 question paper related to the obstetrics questions. So starting with the first question, which of the following is least likely to be a complication of uterus didelphys in a 25-year-old female? So uterus didelphys and least common complication is what is asked. So to begin, how does a uterus didelphys look like? Like this, isn't it? It can have two separate uterus. It has two separate uterus which is not fused at all. If it is partially fused, then it becomes a bicornuate uterus, isn't it? So if it is partially fused, it's a bicornuate uterus. It is fused but the septum is not completely resolved, then it becomes a septate uterus. That figure I'll show you in later photos. So this is a uterus didelphys where there is two separate uterus which is not fused at all, and they can have two separate cervix and two separate vagina also. Okay, so this is how it looks like. So coming to the complication related to pregnancy, as you can see here, the space is very less, isn't it? The space for the baby to occupy is very less. So the complications like abortions, preterm labor and all are pretty much high. IUGR, growth retardation, early mid-trimester abortions, these things. So what are the complications they have mentioned? Preterm labor. Yes, preterm labor is a complication. Why? Because the uterus, the space for the baby to accommodate is very less. Only one horn of the space can be occupied. Endometriosis. Why? Yes. Why endometriosis can happen? Imagine if one of this is blocked. Okay, it can be blocked also. If one of this is blocked, so whatever endometrial shedding is happening is getting collected inside, and retrograde metastasis of the endometrial tissue can happen, and it can get implanted anywhere else also. So this theory says to be as high chance of having a endometriosis, especially in anomalous uterus. Endometriosis is very common. Okay, next coming to transverse lie. Okay, what happens in transverse lie? The baby has to be accommodated like this, isn't it? Now the baby cannot be accommodated in transverse lie in a didelphys uterus. Why? Because the space itself is very less. It won't stay in a transverse lie. It will occupy the space which is more, isn't it? So transverse lie will become the least common complication. Yes, malpresentations and malpositions are common in anomalous uterus. Okay, like for example, if there is a septate uterus, high chance of having breech presentation. So these things are common in a septate uterus, but in didelphys uterus, having a transverse lie is least likely. Why? As you can see, it is completely depressed. There is no space for the baby to lie in a transverse position at all, isn't it? So that becomes the least common complication. So this becomes your correct answer. Abortion, yes, again as we have told, since the endometrium will not be good, the implantation problem will be there, leading to first trimester, or in second trimester, abortions of anomalous uterus is most common. One of the commonest reasons for second trimester abortions is anomalous uterus, isn't it? So here's mid trimester. The space for the baby will be very less to expand. IUGR, preterm labor, mid trimester abortions are the commonest complications related to pregnancy. Okay, so the correct answer here will be answer C. Going ahead with the next question, a pregnant woman with mitral stenosis, okay, mitral stenosis, heart disease in pregnancy with prosthetic valves, okay, artificial valves are there, is currently on warfarin therapy, okay, warfarin therapy at 36 weeks of gestation, okay, everything is important, every single point is important, with INR of 3, okay. So what is the INR to be maintained in case of a patient on anticoagulant therapy? INR should be around 2.5 to 3.5. So this patient is well maintained INR. What should be the next step in her management? So now you know the INR is correct. Warfarin in second and third trimester is good. She is a mitral valve stenosis with artificial valve. Prosthetic valves are there for her, for which she is on anticoagulant. Okay, this is what the history says. Now at 36 weeks, can we continue her on warfarin therapy is what is the question. No. When can you give warfarin in pregnancy? You can give in second and third trimesters only. Okay, because if you give in first trimester, there is very high chance of having a warfarin embryopathy. It is a teratogenic drug. So it is not advised to be given in the first trimester. So you can give in second and third trimester. Again, coming to the labor, it is contraindicated not to be given during labor. So during labor or later third trimester, when you are planning induction or in labor, it has to be stopped. So now at 36 weeks and a heart disease patient, you will try to terminate her by 37 weeks. So you have to stop warfarin and convert her to what? Yes, low molecular weight heparin. So you have to start during labor. What you have to give? During labor you have to give low molecular weight heparin, isn't it? So when you give this, then you can plan your induction of labor. Okay, so now what is the options given? Stop warfarin and start heparin. It is not just heparin, it is low molecular weight heparin. So let us see if that option is given. Stop warfarin, start LMVH and aspirin. Both are not required, only one, LMWH. Continue warfarin. No, you cannot continue during labor. Stop warfarin and start LMWH. Okay, that is what is the correct answer. So coming to some more details of warfarin, because it is commonly asked. So as we have told, it is not given in first trimester and labor. It should not be given in first trimester and labor, given in second and third trimester. Why we prefer warfarin over LMVH in second and third trimester? One is cost. It is cheaper, easily accessible, injectable. Daily take injection for a low socioeconomic status would be difficult, and also it is tedious. Maybe people will not be so compliant on taking daily injections. In such case, you can give warfarin in second and third trimester. But nowadays in general practice, everybody is giving LMWH only, even for second and third trimesters. Okay, so warfarin can be given in second and third trimester. Starting of 50 mg, then you can lower down the dose. How can you lower down? Based on her INR values. INR should be between 2.5 to 3.5. Okay, this is how. Why warfarin is preferred? As we told, one is cost, the other one is compliance is better, and lastly, if you start her on a low molecular weight heparin, the dose has to be keep on adjusting based on the maternal weight. Okay, in second and third trimester, even if you start her on LMWs, low molecular weight heparins, you should keep on weight adjustment of the dose should be adjusted based on her weight. Okay, and also continuous monitoring of her coagulation profile and factor 10A should be done. Okay, if you are giving her low molecular weight heparin. So in non-compliant patients, it's better to give warfarin in second and third trimesters. Okay, going ahead with the next question. A woman who had dilatation in curettage. Okay, she had dilatation in curettage for molar pregnancy. Okay, it is an abortion for molar pregnancy. What is the best method for treatment for molar pregnancy? It is suction and evacuation, not dilatation and curettage. Anyways, 6 months ago, okay, it's been already 6 months she has undergone a dilatation and curettage. Now presents with ongoing abdominal pain and distension, presently elevated beta HCG. Okay, there is elevated beta HCG here and cannonball lesions on chest X-ray. What is the most appropriate management in her condition? So now you know that from GTD, gestational trophoblastic disease, that is maybe a complete or incomplete mole, it has got converted into a gestational trophoblastic neoplasia. Now you have to give her a chemotherapy, isn't it? So based on her risk factor, whether she is low risk or high risk, whether you will decide whether she will require single agent chemotherapy or multi-agent chemotherapy. So what are the high risk factors in this patient they have given? First high risk is she is 6 months, that gives a point of 1 point, and then ongoing abdominal pain, distension, persistently elevated beta HCG. Second is beta HCG is elevated. So let us think maximum number of points for beta HCG will be 4. Okay, they have not mentioned the value, but still we'll keep it as 4. Okay, then third is cannonball lesions. Cannonball lesions, is it a high risk factor? No. Lung and pelvis metastasis is not a high risk factor, that carries 0 points itself. So the total score here will be 5. So score of 6 or less than 6 is considered to be low risk. So this makes her to be giving a single agent chemotherapy. So what will be the correct options? Methotrexate, Emaco regimen, hysterectomy, methotrexate with folinic acid. Yes, alternate dose, isn't it? We won't give only methotrexate. We'll give methotrexate and folinic acid. So this will be the correct choice of treatment or appropriate management in this case. So let us see what are the other low risk and high risk category. How will you divide them? Yes, to begin with the age of the patient. So age of the patient is if it is less than 40 years or more than 40 years, 0 and 1 point. Then antecedent pregnancy, whether it was following a molar pregnancy, following an abortion or following a term pregnancy. Ours was a molar pregnancy itself. Okay. Then interval months. If it is less than 4 months, it is low risk. And 4 to 6 is 1 point, and up to 1 year, 6 months to 1 year will be 2 points, and more than 1 year will be 4 points. This is after how many months of treatment as she again got the symptoms. Okay, then pre-treatment HCG levels. normally in initial beta HCG levels will definitely be in lakhs only. So usually we consider this 4 points. Otherwise, it can be in thousands also. So 1000, 10,000, lakhs and more than lakhs. Largest tumor size of more less than 3 centimeters, 3 to 4 centimeters and more than 5 centimeters. Sites of metastasis. This is one of the most important ones. Sites of metastasis. Lung and pelvis metastasis not considered to be high risk. They carry 0 score itself. Okay. Then spleen and kidneys carry 1 point. GI tract and liver carries 2 points and brain metastasis carries the highest point, that is score of 4. Okay. Then number of metastases, single lesion or multi lesions, 1 to 4, 5 to 8 and more than 8. Prior chemotherapy, whether she was received chemotherapy and this is a remission of the symptoms, or this is the first time she is going to receive her chemotherapy. No chemotherapy, and one single drug therapy is 2 points and multi drug therapy is 4 points. Okay. If a score of 6 or less than 6 is considered to be low risk and 7 and more is considered to be as high risk. Okay. Next question, a female patient with history of 3 miscarriages underwent diagnostic procedure based on the image provided. Which investigation was performed? Okay, what is the image given? It is a photo of a X-ray. You can see a bicornuate uterus, isn't it? Bicornuate uterus can be seen with a dilatation of the tubes. The tubes are dilated and at the fimbrial end there is collection of the fluid. There is no spillage also. This investigation is what? It is a hysterosalpingography, HSG, isn't it? You have seen in your internship all these photos also, I'm pretty sure, or even in your OBG classes. So what happens here? You will put a dye and then you will take a X-ray. So this X-ray will show whether the tubes are filling or there is a spillage or no. This is one of the tests done for to know the patency of the fallopian tube, isn't it? So this is a X-ray. Let us see what is the investigation done is what is they have asked. Saline infusion sonography. Again, sonography is a ultrasound picture, isn't it? This picture clearly says this is not an ultrasound picture. So directly you can say it as no. Hysterosalpingography. Yes, this is an X-ray, correct? Hysteroscopy. This is not a hysteroscopy photo, definitely. And transvaginal ultrasonography. Again, it is not an ultrasound photo also. Okay, so this is one of the easiest question, I believe. There is only one option they have given as an X-ray option. Rest all are graph and direct hysteroscope they have given. So what is the first image that is given? This is an image of a hysteroscope. You can see the uterus from inside. This is the uterine cavity where the hysteroscope is going and you can see the uterine cavity. You can see the ostia. So this is a photo of a hysteroscope for your next exam if they ask you similar photos. And this is a photo of a, second photo is a photo of a laparoscope. Yes, correct. Laparoscopic photo. You can see the uterus, you can see the ovarian, enlarged ovary, and this is a photo of a saline infusion sonography. You can see saline distension of the uterus and this is the endometrial polyp. Okay, you can see the polyp also. So this is a saline infusion sonography. This is the 3 different other options they have given. Going ahead with the next question, a 30-year-old woman with history of 3 miscarriages. Okay, one at 8 weeks, one at 11 weeks and with no cardiac activity, and third at 24 weeks due to early onset preeclampsia is being evaluated. What is the most likely diagnosis? Such a clear picture they have given. So here there is 3 abortions. Okay, 3 abortions means it is a case of a recurrent abortion, isn't it? So in recurrent abortion, if a patient is having, this is one of the criteria, I'll show you the criteria in next photo. So one at 8 weeks, one at 10 weeks, normal morphology with no cardiac activity here, okay, and one at 24 weeks with early onset preeclampsia is there. So all this fit into what? APLA, isn't it? Antiphospholipid antibody syndrome. So this is the clinical diagnosis, clinical criteria for APLA. I'll show you in the next photo what are the different criteria. So APLA becomes the correct answer. Coming to torch infections, yes, torch infections do cause abortions, but very less likely to cause a recurrent abortions. Okay, so recurrent abortions are less likely, whereas it can cause repeated abortions too. Okay, coming to syphilis, yes. Syphilis, what happens? Initially, they will be having abortions, first trimester, second trimester abortion, then intrauterine death, then IUGR, then a normal fetus will be there. Okay, normal fetus. So this is how in syphilis the progress happens. They will not have early onset preeclampsia. So this is called as what? Kazowitz's law. Many times this question also is called asked for you. What is Kazowitz's law, or this law is seen in which case? So it isn't seen in a syphilis case. Okay, so Kazowitz's law says it is a sequential development. Initially first trimester abortion, second trimester abortions, intrauterine death, IUGR baby, then a normal fetus will be there. So this is how the sequence follows. Okay, so this is mostly seen in syphilis. Coming to last option, gestational diabetes mellitus. So what happens in gestational diabetes mellitus? Here the onset is only after 20 weeks. So it will not cause 8 weeks and 10 weeks abortion. Usually the human placental lactogen or insulin insufficiency will be there, or resistance will be there mostly after 20 weeks period of gestation, isn't it? So there is less likely chance of having these complications. But remember, if it is diabetes mellitus, they can have a chance of having early onset abortions, but not in case of a gestational diabetes mellitus, very less likely. Okay, so the here correct answer will be antiphospholipid antibody syndrome. So coming to the criteria, what are the clinical criteria? One or more unexplained deaths of a morphologically normal fetus beyond 10 weeks, severe preeclampsia as in our case, placental insufficiency necessitating delivery before 34 weeks, 3 or more unexplained consecutive spontaneous abortions before 10 weeks. So they had given 2 of these for us and 1 of this. Okay, so this fits into our criteria. That is why we chose this as the APLA as the correct answer. One more thing you have to notice is vascular, if not pregnancy related. If they have vascular, 1 or more episodes of arterial, venous or small vessel thrombosis in a tissue or a organ. Okay, so these people are also having high chance of having APLA. Okay, so antiphospholipid antibody syndrome. So in such case also, if somebody has history of DVTs, then also you have to give low molecular weight heparin. Okay, then coming to the laboratory criteria, there are 3 antibodies that you have to test. One is lupus anticoagulant, another is a anti-cardiolipin antibodies, and lastly anti-beta-2 glycoproteins. These are the 3 important antibodies that you have to check for, okay, to rule out APLA syndrome. So this ends the short discussion of NEET 2021 questions. For a detailed discussion of the individual topic, you can go through our individual classes, lecture classes of the individual subject or individual topic. I hope you have understood well and you'll be able to answer best in your exams. All the best.